Thank you very much. And again, this is, I know that there is another debate also to say that TAVR, so I'm not going to discuss the outcomes of TAVR here. I'm just going to talk to you about something new and novel that we like to do to assess the aortic valve severity, things like that. So, you know, the typical clinical situation, as so many things that you saw today, is this, that patients are coming, symptoms, not symptoms, severe AS, and then moderate AS, low flow AS, all kinds of things are happening. So, of course, the most important things is transthoracic echo and cardiac cath. So these are the two things that happen in most of the patients that come to see us. So one important question that comes up is that when you're measuring the aortic valve area, so remember that nowadays we do a CAT scan, and then we measure the aortic valve area, and that aortic valve area is the peak aortic valve area, because that's not a mean aortic valve area. And what you measure on the echocardiogram is the mean aortic valve area. So there is also an issue with that sometimes people say that this is not a very severe valve because it opens quite a bit, but it is only opening quite a bit for a very brief period of time. So the amount of time the valve stays open is also an important consideration when you're measuring this valve area. So this is something to keep in mind. The second part, this is a simple thing to keep in mind, that when you are assessing a patient with aortic stenosis, you have different kinds and the stages, in the sense that this is, you know, getting a lot of ways of thinking because of the fact that a lot of moderate AS patients with without symptoms are coming. So there is no cardiac damage versus there is LV damage, left atrial enlargement. Of course, in the rare situations, you have the tricuspid valve and the RV damage. It does not mean that this is related to the aortic stenosis. So this is important to keep in mind, that sometimes people used to think that this is one is the cause of the other one. It's not. But even if the heart is damaged for whatever the other reasons are, now the aortic stenosis has a different consequence. So this is what I think is an important message to understand. So it's not like a tumor that is metastatizing. So it's not causing the LA dilatation and then causing RV failure and then it's causing our tricuspid regurgitation. No. But people who have tricuspid regurgitation for whatever the reasons are, and now they have aortic stenosis, what is the outcome? So this is where I think these cardiac damage stages are somewhat important. And then if you look at other things, that severity symptoms are important. And so these are the trials. TAVR Unload was published, as you saw, 2 days ago in JACC. It was published. And then Early TAVR was published in New England Journal, and the Recovery and Avatar are published. So these are all some of the published literature in the recent times. The one thing is certain, that if you have aortic stenosis and symptoms, you are not going to live long. And this was the first paper that was published by Dr. Braunwald and cited many, many times. And it has 12 patients with hemodynamic data, 12 patients with hemodynamic data. So it's very visionary that he identified this kind of a response. And then there were 53 patients with necropsy study in 1937 that he included in this particular analysis. But the idea was that whatever, the syncope, heart failure, chest pain, you are dying very, very fast. When we did the study with our partner trial, this was the first trial that we did, and very painful, 179 patients in 2 groups. Very important to recognize that 100% of them died who did not have, except one patient, who did not have aortic valve replacement at 5 years. So this was a terrible experiment that we did. One patient was alive without AVR. So Now, this is another important thing to keep in mind, that if you have low gradient AS, there are 2 things. So this is a classic low flow, low gradient AS, where the EF is low, or EF is normal, and then there is paradoxical low flow, low gradient AS, where the stroke volume index is low. But there is something as normal flow, low gradient, and that I think is questionable. When you find these things, then you try to figure out what's wrong with the investigations. So these are the 3 things that are very important to keep in mind, that the EF, and because these are the things that come day in and day out. When we see all these patients, So the questions for low gradient AS is that, is it a severe AS or not? So this is an important thing. And nowadays we depend on the anatomy. We don't do dobutamine echoes and things. We said anatomy is very important. Then the second is significant AS for whatever the heart is, stage heart is in. Is it significant for the heart or not? So this is an important question. And is it a treatable AS? Because what is the investment you're going to make depends on how much benefit you are going to gain. So sometimes we'd make the investment even if it is not too risky. So is the flow measurement accurate? Is the gradient measurement accurate? All these things are important to understand, and anatomy is accurate. So I like this thing that, if you are going to measure, so one of the things that we did initially was to say that, people used to say the carotid upstroke is delayed in aortic stenosis. So the idea is that if carotid upstroke is delayed, how is it, how can we measure it? So simple way to measure it is that when you go to the cath lab and if you measure the peak-to-peak gradient, that you will see that there's a difference. Aortic pressure is obviously later, and the LV pressure is faster. And we found that the 60 milliseconds or more was one of the indicators, even in the patients with low gradient AS, to say that this is an important measure. So this is something to keep in mind, that this is important. Echocardiographically, I think this is, I know I'm I'm an interventional person, but I'm talking to the echo people, but these are all the measurements that I live every day and out. So I like this particular measurement too, to say that what is the time to peak. So similar concept is to say that if the peak to the time and the total time, if this is more than 0.35, then this valve is not good. So this is something to keep in mind, that this is another way to measure, and we are analyzing all these different things in different kinds of patients. Of course, the echo assumption is the circular shape, as you know, and of course the velocity profile is the flat profile, which both of them are not true. But because these two things negate each other, it turns out to be a good number. Cardiac output measurement in the cath lab, if they tell you that they measured cardiac output, you must ask, how did you measure it? Because this is a very important problem with the cath lab, that most people these days measure with a fixed cardiac output, and they don't measure oxygen consumption. So might as well guess it. So because you are going to guess the oxygen consumption, so there is no point of saying that the cardiac output is this or that. So unless they measure the oxygen consumption, it's no good. Thermodilution, in my opinion, is better. At least it has a less variability. So if you are going to really measure the aortic valve area, then you should do that. Again, the different types of cutoffs that you use for the MDCT, and then we have a nice paper from Cleveland Clinic to say that even with contrast-related CT scan, you can measure the amount of calcium. But the numbers are different. So this is also important to know that how they measured it, what they measured it, also look at it, because many times people catch the calcium that is not really on the aortic valve, and they are catching it on either in the annulus or in the STJ. So these are, again, something very, very important, like how you check the bone density, and you saw that where they put the square is completely nonsense. So similarly, this kind of things can happen, so you may want to know what exactly you are seeing. The low flow, low gradient AS, whatever it is, the guidelines are that you got to treat it. It is, if it's real, then you treat it. I just want to say early TAVR study was positive. Again, these are the patients who are severe AS patients who are not having symptoms, and then try to see whether we are going to make a difference. Again, most of these patients, you should consider. And there are a lot of different ways. We are following them with either BNP, LV thickness, wall stress, or even high-sensitivity troponin. So these are the four things that we keep looking at. And some very rare patients, we also want to exercise them if the gradients are not 100%. But in this particular group of patients, the aortic valve replacement was done in most of the patients. I just want to conclude with this, that what is the TAVR? I know that all of you have seen it, but just one more time to see. TAVR is done with no general anesthesia, no Swan-Ganz catheter, no art line, no Foley, nothing. And one side groin access with a sentinel device in the wrist. And when we put the sentinel device and then we are deploying the valve, this is pacing for 20 seconds, and we are deploying the valve. And after the valve deployment, we are checking the aortic regurgitation with a dye injection. We know where the valve is placed, so whether we can put a new valve or not. And we are assessing the valve with echocardiogram at the end of the procedure, even decreasing the aliasing velocity, saline injection, whatever it takes to make sure that there is no AR. And we are measuring hemodynamics at the end of the procedure because patient is awake and all that. So we are measuring what is the LVDP, what is the dicrotic notch, what is the gradient. Everything is done, holding the pressure, and then discharging the patient the same day. So remember that all the discussions we have, you have to keep this in mind, that what is happening. What is happening to the patient is like a miracle. So patient is discharged on aspirin only, not dual antiplatelet therapy, no NOAC, and they're followed next day in the office, 1 month and 1 year. So this is a very different kind of an experience for the patient, and this is our data for 5 years. 24, I can add it, but I have not yet added it. But it is 4,000 patients, mortality is 0.4, stroke is 0.5, AR is 0.4, and permanent pacemaker is 3.2%. Very, very hard. Very, very hard to argue. And these are many high-risk patients. Most of them are high-risk because that's what we are doing. So this is something to keep in mind, that patients are referred. We decide the femoral access, this access, surgical access, then decide SAVR, TAVR. But the most important part is the 3D anatomy. If you are a low-risk patient for TAVR, then it gives you a different option. So this is something to keep in mind. So heart team assessment, of course, is very important. Anatomical diagnosis is critical, and lifetime management should be considered. Thank you.